Welcome. We have people joining. Thank you, everyone. We're going to get started in just a moment. We did have quite a few people sign up to register, so I'm excited for a good discussion tonight.
Me too. It's overdue.
Long overdue, and something tells me that it'll be the first of many. It'll be the first of many, Dr. Malone. So I do want to be mindful of everyone's time. We only have an hour tonight, and I do think it'll go pretty quickly. I want to thank everyone who is able to join us this evening for a fabulous conversation, a long overdue conversation, as Dr. Malone mentioned, with Dr. Sharon Malone. We'll be talking tonight about Black women, menopause, and HRT, getting the care that we deserve. But before we get started, I just wanted to share a little bit about Menopause Made Modern. I am Camille Wilson, the founder of Menopause Made Modern, and we're a digital platform that provides information, tips, resource, expert insights for women, particularly women of color who are navigating menopause transition. And so I met Dr. Malone almost 2 years ago, and I'm a big fan of hers. And I want to tell you a little bit about Dr. Sharon Malone. For those of you who don't know, she's a nationally known expert in women's health. She's the chief medical officer at Alloy Women's Health, a telehealth company that focuses on women over 40. Before joining Alloy, Dr. Malone was a partner at Foxhall ObGyn, one of the oldest and most successful ObGyn medical practices in Washington, D.C. She's board certified by the American College of Obstetricians and Gynecologists and certified by the North American Menopause Society as a certified national menopause practitioner. Throughout her professional career, she has been active in reproductive rights, reducing teen pregnancy, and eliminating healthcare disparities, which is some of what we'll talk about tonight. Dr. Malone is the youngest of 8 children. During World War II, her parents, both of whom were raised in the rural South, moved to Mobile, Alabama during the migration from farms to cities. She has seen healthcare from both sides, as a physician and as a child of parents who negotiated healthcare for themselves and their families in the Jim Crow South. Despite living next door to 2 hospitals, preventative healthcare was never a part of her family's life. As a result, Dr. Malone's mother would lose her life to colon cancer, diagnosed too late for treatment. This searing life experience has informed how Dr. Malone has chosen to practice medicine and has brought focus to the healthcare issues she has chosen to pursue. In addition to her interests in women's health, Dr. Malone is an avid reader, an amateur genealogist, and a lover of music. She is married to former U.S. Attorney General Eric Holder Jr. and lives in Washington, D.C. They are the parents of Maya, Brooke, and Eric III. So welcome, Dr. Malone. So wonderful to have you with us this evening.
Thank you for having me, Camille. You know, always a pleasure to be with you.
So I'm just gonna kick off with an excerpt that I got from the Washington Post article in 2021. As they mark life's milestones, Black women, by many measures, have worse health outcomes than white women. They experience higher rates of infant and maternal mortality, lower rates of cervical and ovarian cancer survival, and less access to hospice care. Even menopause is different, with Black women experiencing more hot flashes and night sweats than white women. And so I want to just get into Dr. Malone, if we can. Can you talk to us a little bit about the different stages of reproductive life?
Yes, and thank you, Camille. There are really sort of 4 different stages of every woman's reproductive life. And there's, of course, premenopause, and that's everything that leads up from puberty until you hit to perimenopause. So that can go anywhere from 12 to usually your early 40s. And that is characterized by actually regular menstrual periods. And, those are the years usually of your peak fertility. Now, perimenopause does not have a distinct beginning, but it does have a distinct end. Perimenopause is also known as the menopausal transition. And this is some of the language that we sometimes get confused because perimenopause, a lot of the symptoms of menopause start in mid to late perimenopause. It can start as early as your late 30s and as late as your late 40s. That inevitably leads anyone who is born with a uterus and ovaries will eventually embark on this path, and it will end at menopause. And menopause actually starts the moment you have your last menstrual period. But here's the deal. How do you know when you've had your last menstrual period? No one gives you, there's no ticket that gets handed out. You will know that it happens when you look back 12 months in arrears, and you find out that you have had no bleeding up to that point. And the last and the final phase that was on that slide before Camille was postmenopause. And I don't really like the term postmenopause because it implies that there is really another phase after menopause. The menopausal transition is over once you've had your last menstrual period, and then you were menopausal from that point forward. And to use the term postmenopause, and we use it a lot, but what I think what it conjures up is this notion that somehow you are over menopause. You are never over menopause. The average woman, from the time she's had her last menstrual period, you will live in that phase of your life anywhere, if you're lucky, 30 to 40 years. So all of the complications and rights and privileges therein of having had your last period will start at that moment, and they will continue until the end of your life.
So we almost spend, depending on our lifespan, we can spend as much time or longer in postmenopause as in premenopause. Is that correct?
That is exactly right. And I think it's a travesty that for women who spend this much time in that postmenopause or that menopausal phase, that so little attention has been paid. And, and arguably, this is the time of your life where, you start to see certain health conditions start to crop up. You need to be aware of what to even expect when you get to postmenopause. And to be quite honest with you, most women aren't even, they've heard this term perimenopause for the first time. And here's, and even perimenopause, and I won't belabor this point, but when I tell you that perimenopause can last anywhere from 4 to 10 years, that means that at any point along that spectrum, symptoms can start, stop, pick up again, that all of the things that we normally attribute to menopause really starts in the mid to late perimenopausal period, which really starts to happen by when women are in their mid 40s to their early 50s. And, because you don't really know what's happening and the symptoms don't happen in any particular order, you get confused. You think that there's something else going on, hot flashes, weight gain, sleeplessness, irritability, depression. All of these things can happen in small part or in large part during this perimenopausal period. And some of them will continue after you've had your last menstrual period.
Thank you, Dr. Malone. And we are going to talk a little bit more extensively about more of the symptoms tied to perimenopause. But before we do that, can we just spend a little bit more time? You talked to us about the different stages of reproductive life. Mm-hmm. And you did give us a definition of menopause, but I think it's important for us to clarify it and emphasize what is menopause, because the term is often, I think, misused.
Right. Menopause is that time of a woman's life which really marks the end of your fertility. I mean, during the perimenopausal time frame in your 40s, your fertility is decreased, but it's not absolutely gone. periods stop at menopause. They should. And if you have bleeding beyond those 12 months that we talked about, if you've gone 12 months and no period and you bleed again, that's something that's actionable. You should tell your doctor if 2 or 3 years after your last period, you're bleeding again. But the really hallmark of menopause is that it's the end of a woman's reproductive period. And it is accompanied by no periods, and plus or minus symptoms. And I think here's another sort of misconception that I hear a lot. Women will say, I didn't go through menopause. I'm like, yes, you did. There is no such thing as not going through menopause. If you have ovaries, you will go through menopause. Now, it does vary from person to person in terms of how many, some women will have no symptoms, and lucky you, but that is the minority of women who will go through this transition and don't have symptoms. Another thing I think is confusing for some women is that, it's not uncommon. Black women have a disproportionate chance of having had a hysterectomy. And so when you don't have a hysterectomy, when you've had a hysterectomy, and I tell you that the first sign that you have that you're sort of entering this perimenopausal phase are usually some subtle changes in your menstrual cycle. When you're in your 40s, the periods start out being too frequent. You'll say, oh, instead of being every 28 to 30 days, you notice that your period is coming every 24 or 25 days. Also very common during this perimenopausal phase is the quality of your bleeding. You can bleed too heavily. You can bleed too long and too frequently. And that is a very reliable indicator that women have entered perimenopause or the menopausal transition. And obviously, if you've had a hysterectomy, you don't know that because the bleeding has stopped because you no longer have a uterus. And that, I think, leads to some confusion about where women are in this sort of menopausal spectrum.
Okay, so maybe we can shed a little bit of light on that by talking about the symptoms of perimenopause. So for those who say that they have not gone through menopause, this list might be a little shocking to them. Right. And there are 34 recognized symptoms, at least this is what I pulled from Mayo Clinic. Some claim that there are more, but these are the 35 recognized symptoms associated with perimenopause. And so can you talk a little bit about what some of the most prevalent symptoms are and how we experience them over the course of perimenopause?
Sure. You know what, when sometimes when people ask me, well, what are the symptoms of perimenopause? And I say, everything, everything, and that's what makes it so confusing for women. But to be honest with you, the things that are most common are the hot flashes, the night sweats, the moodiness, sometimes depression, palpitations. Women will complain of having these, feeling that their heart's pounding, that may or may not be associated with anxiety. There are changes in just your sexual, in your libido. Some women find that it's higher, some find it lower. But I tell you, this is another thing I think that's important to understand the difference between perimenopause or the menopausal transition. I'll use those two interchangeably. And menopause, when I told you when you're at the end of that road and you will get no more periods. In perimenopause, the reason why the symptoms are so varied is because it's not that your hormones are low, it's just that they're erratic. And that's, some days they're high, some days they're low. Some days you produce too much estrogen, sometimes some weeks too little. And what your body is responding to is really that sort of erratic production of hormones. And that's what leads to sometimes some of the mood swings. Imagine when you're in the premenopausal phase for women who have had symptoms like PMS or premenstrual syndrome, you can predictably tell when you're going to get those symptoms because you know where you are in your menstrual cycle. But when you're in that perimenopausal transition, you don't know when you're going to get your next period, if you're going to get your next period. And those symptoms may last 2 days or 2 weeks. And that's why I said it's very confusing for a lot of women. And let's just say if you have the combination of symptoms that would include weight gain or hair loss and thinning of your skin. Now, those are also signs that those are also symptoms of something like underactive thyroid. And that gets confused a lot, that women think, oh, it's something is wrong with my thyroid. I'm gaining weight, I'm losing hair, I'm having this sort of low mood. And the reality is that a lot of women will go to various doctors. They'll go to one doctor who is treating, that is supposed to be looking at their thyroid. They'll go to another doctor. They'll go to a psychiatrist who is prescribing medication because of mood. And, you really need someone who can hang it all together and understand that these are not separate and apart issues. These are all sort of falling under the rubric of this menopausal transition. So, I say to everyone, if you have, those of you who have symptoms, this is going to sound very familiar to you. But for those of you that don't or think that you don't have symptoms, just look at this list and say that there may be some of the things that you may not traditionally associate with menopausal transition that actually are part of the same syndrome.
That's so helpful, Dr. Malone, and to see them in a list like this and to be able to make the connection that they're all could be all related is very helpful and important. And I know I was lost early on in my own journey. Can I ask you, so we've talked about the symptoms. You've mentioned that perimenopause can last from anywhere from 4 to 10 years. And we're still fertile during that perimenopausal period, correct? Is it possible? I know this has been a question I've seen a lot in forums, and I know I've been asked in Q&As. Is it still possible to become pregnant during perimenopause?
That's an excellent question. And the answer to that question, yes, you can, because remember, during the perimenopausal years, you are in a state of decreased fertility, not no fertility. That doesn't happen definitively until you are menopausal. Now, clearly, the older you are, the lower your fertility is, but it's never zero. And that's why we treat perimenopause a little bit differently than we treat menopause. And that is because you're at the end of your fertility. Remember, when you're in perimenopause, you're still getting periods. They may be too frequently, or you may be getting 2 periods a year, or anything in between. So while you are still getting periods, you are still potentially able to get pregnant. And again, and that's something that women should be aware of, because one thing that I I am that child. I laugh about that. I said, I am my mother's perimenopausal baby. I mean, she probably was wishing for menopause, but she got me. And she was almost 45 years old when I was born. And my next sibling to me was 7 years older than me. So I'm sure she was sort of in that process too, thinking, oh yeah, I probably can't get pregnant. And yes, you can. That's why it's really, really important until you get closer and closer to menopause, that when we're trying to treat these symptoms, it's a different approach. And we are trying to do several things. We're not just trying to treat hot flashes and mood swings. We're also trying to give you some cycle control, because again, these irregular, heavy, out of control periods is not uncommon. And we're trying to give you cycle control, birth control, as well as symptom relief. So even though the components of the hormones that we use in perimenopause, it's still estrogen, it's still progestin, it's just at a different level, because you need more hormone to suppress all that background noise going on that is coming from your ovaries, and also give you contraception and cycle control. So that's why they are the same in the concept, but they differ in the amount and the type, but they're still estrogen and still progestin.
Thank you. So another question that comes up quite a bit, and could seemingly be a complex response, but is menopause different for Black women?
The menopausal experience, yes, it is different in the sense that there are a few things that vary. Black women, and this is data that comes from a SWAN, they call the SWAN study, and it's the study of women across the nation, which is this long-term study, which is followed women across the country, and they look at white women, Black women, and depending upon the region where they are, either Chinese or Japanese women, as well as Hispanic women. And they're trying to gather data to see how does this experience differ by ethnic group or race. And what they have found is that Black women tend to have their final menstrual period, which is menopause, about a year earlier than white women do. Black women also, that menopausal transition, when I told you that it can go anywhere from 4 to 10 years, Black women tend to have a longer transition. So they're more on the 10-year side than the 4-year side of that transition, which means that all of these symptoms that we've talked about, the hot flashes, the mood swings, the sleeplessness, the brain fog, can persist for as long as a decade, if not longer in some women. And that's very important because there are certain things that increase your risk of other health issues down the road. And I'll give you an example. They also found that hot flashes and sleeplessness or disturbed sleep are more severe in African-American women. Now, what does it mean to have, other than just being hot and bothered, what does that really mean? There also is an association between women who have worse hot flashes also have an increased risk of heart disease. Women who have hot flashes are also at increased risk of developing type 2 diabetes and also having other issues. So the hot flashes are really sort of like a canary in the coal mine, literally, where they are really markers for things that can be problematic in the future. So hot flashes are associated with weight gain. Hot flashes are associated with increased risk of cardiovascular disease. And needless to say, the more disturbed your sleep, the worse your mood is and your productivity and everything the next day. So, hot flashes are more than just, something to be laughed at or get a fan. I think that the women who are most severely affected are going to have more problems down the road, and not just in the short term, but in the long term.
And so that's really important because we often don't make that connection with these symptoms that we're experiencing, hot flashes, and implications for other health outcomes. Right. So
right.
It's important to treat them.
It's really, and here's another thing that I think is really important is that, what they found through the SWAN study is that Black women also tend to have earlier menopause. And the earlier your menopause, the more likely you are to be at risk for those things that we talked about before too: cardiovascular disease, osteoporosis, developing type 2 diabetes. Now, that's pretty darn important because those have major implications for your long-term health and the quality of your life as you age. So, I think that particularly for African-American women, if you have an early menopause and you are symptomatic, another thing that you may not be aware of is that women who have earlier menopause are also at higher risk for developing cognitive decline or Alzheimer's. And, we know through, again, just observing that Black women are at least 2 times more likely to develop Alzheimer's than white women in this country. And that's a major concern for us as we age.
So we've talked about the symptoms and we've talked about the implications and the seriousness of the symptoms. Now it's important for us to talk about what are some of our treatment options, Dr. Malone? And I know one of the things that is really important to you is to talk about and educate women on HRT and what it is and how it can help them. So can you talk to us a little bit about what is HRT?
Yes. And, and again, because we change the terminology from time to time,
Yes.
HRT was known as hormone replacement. And now you will see some language where it's called MHT, which is menopausal hormone therapy, all the same thing. And what it is just, it consists of estrogen. If you have a hysterectomy and you do not have a uterus, then when you are menopausal or you become symptomatic, all you need is estrogen only. You only need to take the estrogen and a progestin if you have a uterus, because the only thing that the progestin, which is the second hormone that your ovaries normally produce in the second half of your cycle, its purpose, the only purpose for the progestin is to protect the lining of the uterus. Because if you have a uterus and you give estrogen only, the one thing that we do know is that it can lead to overstimulation of the lining of the uterus and possibly endometrial cancer. So that's sort of the two components: estrogen with no uterus, estrogen and progesterone if you have a uterus. And this is something that I think I can't say enough, is that, study after study after study, even the terrible Women's Health Initiative that started this whole scare thing about turning women off from hormone replacement therapy, all of them agree that given for women who are symptomatic, if you have hot flashes, mood swings, any of those 34 things that we talked about, that menopausal hormone therapy is the most effective treatment for hot flashes. And one of the things that we haven't talked about, and that is sort of the vaginal and urinary symptoms that happen after menopause, because even for women who haven't had any significant hot flashes, or the women who think, oh, I didn't go through menopause, it is very common, and I think any woman who is, 50 plus understands this. There are issues of vaginal dryness, painful sex, urinary symptoms such as urgency, frequency, frequent urinary tract infections. All of those things are also part of what we would call that late perimenopausal transition, or the post-menopause. And this is due to the fact that when I told you that perimenopause is because women's hormones are all over the place, sometimes high, sometimes low. Once you get to menopause and you've had your last menstrual period, from that point forward, your estrogen levels are very low, your progesterone levels are very low, and your testosterone, which is also a hormone that the ovaries produce, becomes very, very low. And that low estrogen state is responsible for a lot of those tissues that are estrogen sensitive, like your vagina, like your urinary bladder, like your skin, like your hair. All of those things are estrogen sensitive. So I think when we talk about estrogen as being a reproductive hormone, it is a hormone that when in your reproductive years is produced by your ovaries. However, it affects just about every organ in your body. You have estrogen receptors everywhere, in your brain, in your skin, in your eyes. And here's another little tidbit that has come up as well from the study, is that for women, they also find that women who are Black women in particular benefit most from taking estrogen for even reducing the risk of certain types of glaucoma. So that is sort of, in a nutshell, what it is. And I think that when you're trying to come up with this notion of who should take, who shouldn't take, and I think that's important to know, there are very few exceptions to, I should say, who cannot take hormones. And I think it's important for you to know what those exceptions are. You cannot take hormones if you personally have had breast cancer. You should not take hormones if you have had a blood clot. And by that, I mean like a DVT in your legs or in your lungs, or you know that you have a genetic risk for developing blood clots, or you have undiagnosed bleeding. As I said, you think you're beyond menopause, or you're having some bleeding that no one seems to know what that's about. You should not take hormones until that cause of bleeding has been addressed. And other than that, for everyone else in that category, which is about 98% of women, whether or not to take hormones is really based upon your particular risk profile and your particular symptoms and expectations for how do you want to live the next 30 years of your life. Some women are not very bothered and they're saying, you know what, I'm good. And for them, I'm not going to make that case. There is a lot of things that you can do to minimize your risk of cardiovascular disease, like diet and exercise, and everyone should do that. So, I don't want to, give you the impression that everybody should take hormones. Not true. But what I would like to leave you with is the impression that it is for more women than you would think, because I think a lot of women take the hormone option off the table because they think some things are bad for them. And, it matters too, when we're going to discuss hormone therapy, when do you start? And as I told you before, timing is important. You don't want to take hormones if you've been menopausal already for 25 years now, because most of the symptoms have pretty much dissipated. And whatever risk factors you have for cardiovascular disease and osteoporosis, that's pretty much, baked into the cake. But the women who have early menopause, if you are menopausal in your 40s, which means, again, having had your last period in your 40s, you are going to benefit the most from hormones because you are more at risk for those things that we talked about: cardiovascular disease, osteoporosis, type 2 diabetes. And there also seems to be sort of a window, and this is a little fungible, and we'll talk about that later, but it appears that for women who start hormones before the age of 60 or within 10 years of whenever your last menstrual period was, these are the women who derive the most benefit from taking hormones. So when you do that, cost benefit analysis, if you're below the age 60 or you're within 10 years of your last menstrual period, the benefits exceed the risks. If you have an early menopause and it falls in that same category, the benefits far exceed the risks.
That's great. I want to let folks know, I see folks populating the Q&A. We will be taking Q&A after the presentation. So please don't worry. I'll be sourcing the questions from the Q&A after Dr. Malone's chat. So Dr. Malone, you've talked to us about what is menopausal hormone therapy, the best time to consider taking it at the stage in where we are in our reproductive stage or later stage of perimenopause, or the earlier we start. Can you talk to us about, are there different types of menopause hormone therapy, and how do we think about that?
Yes, there are. Now, once the big divide is to take or not to take. And then once you've made that decision that you are going to take hormones, you can take, and I think it's important to understand what are, and you will see this out there in the literature. Some people say natural hormones or bioidentical hormones, and natural hormones and bioidentical hormones are not the same thing. And because there's really not anything known as that, the only natural hormone that there is out there is one that most women don't want to take. And that is the one that comes from pregnant mare's urine. Now, once people know that Premarin is a natural hormone because it's found in nature, but when you figure out where in nature it comes from, most women don't find that option quite as palatable as you would think. But the rest of them, the bioidentical hormones, they come in two categories. A bioidentical hormone just means that, yes, it's made in a lab somewhere, but it is the exact same chemical structure. If you drew it on a chalkboard and you had all your carbons and oxygens and hydrogens there, it would look exactly like the hormone that your ovaries make. So that's the distinction between bioidentical hormones and non-bioidentical hormones. It's just a matter of what they both work, but whether or not they are identically the same. And the same is true of the progestin. As I told you, progestin is a broad class, and that is that hormone that you have to take if you have a uterus. But progestins can be bioidentical, which means it is the exact same chemically as the structure, as the hormone that your ovaries make, or it can be a synthetic hormone. It still works, but what we are finding in these 20 years of, just observations since the Women's Health Initiative came out, that got us in all this trouble, is that the bioidentical progestin or progesterone, called micronized progesterone, has less of a risk, and I mean, I would say zero risk of breast cancer, because that's one of the things that came out of the Women's Health Initiative that scared so many women away from it. So it is neutral when it comes to breast cancer if you use bioidentical progesterone. But even if you use the synthetic, worst case scenario with the Women's Health Initiative, even that risk was considered small and rare. So different things. Your estradiol, which is the bioidentical form of estrogen, you can take it as a pill, you can use it as a patch, you can use it as a vaginal ring even that you can put in. It comes as gels and creams, many of which are FDA approved. So it's not as if, you're taking a crapshoot about what you're getting. It is estradiol, and whether you want to use it orally or what we call transdermally through the skin as a patch or a cream or a gel, that's a matter of personal preference. And for women that don't have a lot of other of the symptoms like the hot flashes, or let's just say you are 20 years beyond the menopause and your symptoms are mostly urinary, there's also estrogen that you can use vaginally. And anyone can have that. It doesn't matter whether you're, you can have it if you're 80 or even if you have had breast cancer, because the amount of estrogen in the topical vaginal estrogens is so low that it does not, it basically does not increase your risk really of anything. So those are just kind of, the range of things is quite wide. And the only thing that I would caution you about really is some of the compounded. Now, see, we use these terms, but compounded hormones are these hormones that are not FDA approved, and they're not made in by traditional. You can't buy a compounded hormone from CVS if your doctor writes a prescription. These are these sort of designer. Someone has said, "Oh, I'm going to give you, I'm going to say you'll see a naturopath, and then they do $1 million worth of blood work, and then they do salivary test to find out what your hormones are, which you do not need, by the way. And then they compound something up, or you get pellets. These things, and I want everyone to know this, they are not FDA approved. There is no duty to really prove that they are safe or effective, or that they have the amount of hormone in them that they say that they do. Now, let me be honest, there are some compounding pharmacies that are better than others. But how would you know that? Because there is nobody who's doing any purity testing on any of these compounded designer hormones that will cost you a lot of money. And particularly with pellets, when you do a pellet, that is, you go in and get a shot, and they usually give it to you in your butt, and you might feel great. And there are different combinations. Some of them have estrogen, some of them have progestin, some of them have testosterone in them. But the problem is that whether the dose is right or not right, or you're having symptoms or issues with that, there's no way to take it back. If you take a hormone, a pill, a patch, or a cream, if you don't like it, or for whatever reason you have issues, stop taking it. You can't take a pellet back. They usually last for 6 months. So if it's too much testosterone in your pellet, then you're gonna, you might grow a mustache, or have acne or have other symptoms, but you really have to just wait for it to wear off. And that's why I would say, be careful, because if someone is really trying to give you hormones that are not FDA approved, do not by any chance be taken by the fact that somehow that this is more safe than commercially available hormones. They are not. You can have a bioidentical hormone that you get as a prescription from CVS.
So important, Dr. Malone. So thank you for making that distinction, because I think many of us were not, we hear natural, we hear bioidentical, and we think they're the same thing. And so it's so important to understand the distinction. And I did advance a little bit early on the slide where you're talking to us about the different types of menopausal hormone therapy. But we did want to take a little bit of time to just emphasize, because I think one of the biggest concerns is around HRT and breast cancer, menopausal hormone therapy and breast cancer. And so we just wanted to spend a minute or two just addressing that concern specifically. So can you talk about, we know you mentioned the Women's Health Initiative study and a lot of the fear that instilled in women, but specifically around breast cancer, what should we know about menopausal hormone therapy?
And you know what, Camilla, if I had to say, what's the number one reason why women avoid taking hormones, even when they are miserable and most symptomatic, the number one reason why they don't is because there's the fear that hormones are going to give them breast cancer. And women didn't make this up. This wasn't, this is an urban legend. Women got that idea because that's what doctors and the medical community said 20 years ago, mind you. But when the Women's Health Initiative came out, it said that there was a 26% increase in the risk of breast cancer in women who took estrogen versus women who didn't take estrogen. Now, that sounds terrible. Who would want to take something that increased your risk of breast cancer by 26%? No one. And that's what happened. When women heard that, they abandoned hormones in droves, even women who were doing well and had no problems. Well, there was a little problem with that study, and the problem was a 26% increase in the risk of breast cancer. What does that really mean in real terms? If I told you, if you bought my Lucky Charm, you have a 50% higher chance that you're going to win the lottery, it only costs you $100. Well, okay, well, it was, 1 in a million. Now it's 1.5 in a million. It matters what the baseline is. So the percentage may sound great, but even in that flawed study, and we won't go into the details about that, but a 26% increase in the risk of breast cancer in the worst case scenario from 20 years ago only translated to an additional 1 case of breast cancer per 1,000 women per year, less than 1. So if someone told you that those were your odds of getting something as a result of this, and that was only in the women who took estrogen plus the synthetic progestin. And the most important thing that this study did not really clarify for women is that risk only was for women who were older. For women who took hormones around the time of the natural menopause, is when we get them, that increase in the risk of breast cancer did not stand. So that's number one. We got this in our head because we told you that. And it turned out that on closer inspection, that was not true. We have 20 years of data now after the Women's Health Initiative. And guess what we found? And this was even in the Women's Health Initiative. Remember those women who had hysterectomies? That 26% increase in breast cancer, or that 1 per 1,000 women per year who had an additional increased risk of breast cancer, only they had no increase in the risk of severity of their breast cancer or death from their breast cancer. That's 1. And 2, for those women who had had hysterectomies, guess what they found? Women who took estrogen only and no progestin had a 30% decrease in their risk of developing breast cancer, which is counterintuitive to everything we just said, because we're blaming estrogen. And you have to say, well, how can it cause estrogen in one set of women and decrease it by 30% in the other? And the difference is that the player here has to be the progestin, because the women that didn't take progestin actually did better. And this is why I'm going to make a case for Black women and Black women who have had hysterectomies, of which there are quite a few. Then that means that taking estrogen to treat your symptoms after menopause actually decreases your risk of breast cancer, decreases your risk of dying from breast cancer. And overall, because of these things that we talked about, like the decrease in risk of cardiovascular disease and type 2 diabetes, your overall risk of dying from any cause is also decreased 30%. And the second reason that women sort of avoid hormones is because they will say, well, no, I can't take hormones. My mother had breast cancer. I can't take hormones because my sister had breast cancer. And this is what the newest guidelines from the North American Menopause Society has clarified. They've looked at women who take hormones who have a family history or don't have a family history of breast cancer. And guess what they found is that whether you take estrogen or not does not increase your risk of developing breast cancer. Your risk of breast cancer is your risk. You know, the question is, am I adding anything to that by taking hormones? I can't tell you who's going to get breast cancer and who's not, but adding hormones to that mix does not increase your risk of breast cancer any more than being 20 pounds overweight, having 2 glasses of wine a day. That's the amount of nominal effect that it has, even in the women who took estrogen and progestin. So it's a lot of unlearning. And when I tell you, it's not just unlearning with patients. There are doctors who are still stuck and prescribing as if it were 2002. And, you know, I think for people who have questions about this, the question is, where can you go? Because I know for a fact that there are women who are on hormones, who have been on hormones doing great, and they will go see their primary care doctor, and their doctor will tell them, oh, no, you have to get off this, you know. And just as if a patient came to see me in my office, and I'm a gynecologist, and they're on a particular high blood pressure medication, I don't do high blood pressure. I wouldn't change your medication or tell you to not take something, because I'm going to stay in my lane. But when it comes to hormones and women's health, everybody feels like they get a say in this. And there are only a few people that are up to date and who know how to manage women of a certain age. And we've really got to change that. And that's really the key. We've got to get women to understand, and again, and as it relates to Black women, here's an interesting statistic for you. For Black women who are symptomatic, they are only half as likely to even bring it up when they see their doctors. So if you see your doctor and you're having hot flashes and you're miserable and you're not feeling great and you're depressed and you don't bring it up, chances are very likely that your doctor's not going to ask you about it, because the default is always, well, you didn't bring it up, so it must not be a problem. So if you don't bring it up and know what the symptoms are to be able to have someone address that for you, then you're not going to get a solution to your problem. And another interesting statistic, for even when Black women see their practitioners and they bring it up, and they are only half as likely to get a prescription, even when their symptoms of menopause are clearly that, and they don't prescribe it. And that's because a lot of doctors feel like, and this is one of those things about education. The old way of thinking is that Black women don't get this. They don't get osteoporosis. Oh, you're overweight, you can't take hormones. Not true. And so you figure half of the women are not even going to bring it up. The half that do bring it up are only half as likely to get a prescription. And then once a prescription is written, only about 24% of those women, once they've been given a prescription, will go fill it and take it. Because there's a lot that's going on here, because we've got to, again, realize that we're talking to our friends, you're talking to your hairdresser, you're talking to this person, you're talking to the person at the, GNC vitamin stand who is telling you not to do this. And so there is a huge number of Black women out there who are undertreated for their symptoms. And to me, that is a travesty, because it's not just a matter of being uncomfortable. It's not just a matter of, oh, let's go get a fan. These are real life, quality of life issues for you on a day-to-day basis, and long-term health issues for you, for years down the road.
So I can't believe how fast our time has flown. And so I did pull this up. You spoke to some of this, but one, I think, bullet we have to add is, for a better menopause experience is not just track your symptoms, talk about them, right? Talk about them with, anyone who will listen, but most importantly, your doctor. And I do want to call this one out, consult a doctor who understands menopause. Right. Unfortunately, there are some practicing who don't have the understanding, the insight, the education specific to the needs of women going through perimenopause and menopause transition. But there are resources, and there are all kinds of communities to tap into. And just wanted to highlight a few. There's so many wonderful resources that are out there for us to tap into, and these are just a few. Of course, Menopause Made Modern, which again, I focus on developing content and bringing information like this conversation with Dr. Malone to you, specifically for Black women and women of color. This discussion tonight was specifically about Black women, menopause, and HRT. Let's Talk Menopause.org. That's Let's Talk Menopause. They're a wonderful nonprofit organization doing advocacy and fighting for policy in the space. Menopause.org is the North American Menopause Society. And so you can also visit them at menopause.org. They have a zip code locator where you can plug in your zip code and see if there's a certified menopause practitioner in your area. And lastly, Dr. Malone referenced it a couple of times this evening, the SWAN study, which is a longitudinal study focused on women going through menopause, and they do track women of color, Black women, Hispanic women, Asian American women living in certain geographies across the country. And that's the study of women's health across the nation. To learn more about menopause or to get treatment, to sign up for Dr. Malone and the services they offer, you can visit www.myalloy.com, and you can follow Dr. Malone on Instagram or Twitter. That's an easy thing you can do this evening at smalonemd. And download our free e-resource guide at menomademodern.com. There's information about Alloy in there as well. And so we only have a few minutes left. I'm going to stop sharing, and I'm going to go to the Q&A. Hi, Dr. Malone. And for the last few minutes that we have, let's see. We've got some questions. Here's one around how will birth control pills impact menopause? Will my period stop even though I'm taking the pill?
No, your periods won't stop. And this is a great question, because birth control pills are what we generally use when you're in perimenopause, when you're in that menopausal transition. Because remember, you're still getting your periods, but as long as you take the birth control pills the way you would normally take birth control pills, where 3 weeks on, 1 week off, you will continue to get your period, and you will have no idea where you are in that spectrum until you stop the pills and then wait and see if you get another period. Now, to be quite honest with you, does it matter? No, we know that the average age of women having had their last period is about 52. So if you are otherwise healthy and not having problems, you could just stay on your birth control pills until you're 52 or 50, whenever you want to do that test, and then stop them and see. And then at that point, once you are menopausal, which sometimes a blood test will be helpful at that point, then you can switch to the lower level of hormone that you take as menopausal hormone therapy. But yes, menopausal hormones are, you remember I told you those same two components is estrogen and progestin. They just vary in terms of type and amount that between birth control pills and what you take as menopausal hormone therapy.
Great, thank you. This one is, I'm 54 and still have long periods. I have night sweats and a few other symptoms. Am I in perimenopause?
Yes, you are, because remember that you're not in menopause until you've had your last period. So how to treat someone who's 54 and symptomatic? Now, here's some good news and bad news about that. You may or may not want to take birth control pills, particularly if you've never taken birth control pills before, or you've had problems with birth control pills in the past. You can use menopausal hormone therapy, and it requires a little, adjustment, but you can use that to treat the symptoms. And the reason why I say it requires a little adjustment, because you need someone, you don't want to make some of the symptoms worse, like bleeding. But the good news is that, as I told you, one of the things that you need is contraception when you're perimenopausal. It is extremely unlikely, not impossible, but extremely unlikely that pregnancy would be an issue at 54. You might choose something else because of how you want to manage the bleeding, but pregnancy is probably, your likelihood of getting pregnant is probably in the 0.2% category. But, and I'm going to say this to my perimenopausal sisters out here, and particularly since we are in this phase now where we don't know where reproductive rights and where abortion care, how that is going to shake out in this country, it is vitally important for those perimenopausal women who are sexually active and who are certainly in that early phase where pregnancy is more of a possibility. It is very, very important that you use reliable birth control.
Okay, and we have time. We have so many questions for folks who have put questions in the Q&A. We haven't had a chance to get to them. I'll do my best to get follow-up responses, work with Dr. Malone, and get those to you in the next couple of days. I do want to apologize, but we're gonna go for one more question before we wrap up. Okay, I have. No, we did that one. Let's see. Can this help with fibroids? That's an interesting question.
No, it won't help with fibroids. I mean, again, same thing. Your fibroids are your fibroids. What will typically happen with fibroids is that once you get to menopause, having had your last period, because estrogen doesn't necessarily make them grow, but it will maintain them. So once you get to menopause, fibroids, if you do nothing, they will generally get smaller and shrink over time. And again, the amount of estrogen that's in menopausal hormone therapy is much smaller amount of estrogen than even what you make during a natural menstrual cycle. So even though you have fibroids, that's not a disqualifier for women who are symptomatic with fibroids after they have had their last menstrual period. But it was usually a net zero. It's not going to make them worse. It's not going to make them better.
Okay, and so just one more question, because I'm going to push it to the limit. Now, this one I don't know. It's kind of a trick question. I have some menopause symptoms, but still have long periods. When can I expect to go into menopause?
Oh, isn't that the $64,000 question? I wish I could tell. It's almost as if I use this analogy all the time. I said, it's like going in labor. If you're trying to decide whether to get an epidural, and it's like, well, am I going to be in labor for 20 minutes or 20 hours? I don't know. Now, if it's going to be 20 minutes, you might be able to go without it. But if it's going to be 20 hours, you might make another choice, but you don't really know. And there's really no predictor. We can just say, generally speaking, the earlier you start having symptoms, the usually, and when you're in your early 40s, the longer they tend to persist.
And so that does have to be the last question because we are at time. Again, thanks for everybody for joining us this evening. Thank you for registering. Thank you for attending. We'll do our best to get back your responses to the questions that we didn't have a chance to get into in chat. And I also wanted to thank Alloy. Dr. Malone and her colleagues at Alloy have made a discount code available, MMM25. Again, that's MMM25. I'll include that in the follow-up email, and that'll give you $25 discount off your first service with Alloy. And so please take advantage of that and keep an eye out for the next webinar. Thanks again. Thank you, Dr. Malone, and thank you all for joining us this evening.
Thank you.